This is the third date?
Yeah. Walked right out of the theater, never saw her again.
Just because she called it Reese's Pieces?
It's common English. It's pieces. The man was named H.B. Reese. They're his pieces. Pieces isn't even a word. We're talking about candy, not a horoscope here.
Okay, all right. I mean, fair.
Absolutely unacceptable.
Deal breaker, I guess. So,
well, hello and welcome to Seitz and Sirens, a Back to Basics podcast, where I, a paramedic nurse, and my brother here, Chris, ER physician, talk about what may seem like complex medical issues, and we break it down into the basics and have a little fun doing it. So, Chris, why don't you introduce our sponsors today?
All right, yeah. So today's sponsor is Rapid Rescue. Rapid Rescue is an EMS training company that does AHA courses like we do, but they also are doing EMT and paramedic refresher courses through JB Learning. So if you actually enroll in our program for NREMT prep, you get access to their refresher program through JB Learning. So today, topic I want to talk about is amputations. And the reason I want to talk about this is that I think it can be a very intimidating not topic, because it's kind of an exciting topic. I think sometimes we enjoy getting into these kind of things in EMS and emergency medicine. Yeah. But it can be a very intimidating situation. I've experienced this multiple times in my career so far as an ER physician, but it never fails to be intimidating when someone walks in. Usually they don't walk in. Usually you bring them in, but somebody brings them in, and there's an amputation of an arm, a leg, that sort of thing. It's kind of surreal, I think, a lot of cases. But I want to talk about how maybe that intimidation and that what seems like a complex situation could actually be really basic for us, because the management is going to be pretty basic. So I'll start with a little bit of a story. So this was a case I had, and like I said, kind of talking about how this is an intimidating situation to be in. I was working at an emergency department in New Hampshire, and this was kind of like up near the White Mountains like area. So we didn't have a lot of transport opportunities. We flew a lot of people out of this facility because, like I said, there was no real good way to ground transport people. It took a long time because the EMS ground transport would have to go around all the mountains and stuff. So it was easier to fly a lot of people out. We had decent resources at this facility, but it was a smaller facility.
See, to me, when you say that, we're from the Midwest. Like, to me, it makes it sound like they needed to take the Oregon Trail or something. Like, when you say they can't really navigate the mountains, we need to fly them.
No, but you know what I mean?
It makes it sound like this is just surrounded by mountains, and they had to prep for the journey in a covered wagon.
Okay, they don't have covered wagons, but yeah, I mean, it's kind of this hospital is kind of surrounded by mountainous areas, so it just takes a lot longer to drive anybody out of there than it is to fly them out. So we flew a lot of people out of there when we needed to transport. We had pretty good resources, but as the emergency physician, when I worked, I was the only physician on. So I was the only emergency physician on. We had other physicians in the hospital. Some of them kind of came and went certain days of the week. So you never really knew exactly what services you had on different days, which, again, can kind of be intimidating in and of itself because it's kind of just you. Obviously, you've got a team of nurses and stuff like that as well. But I got a call from EMS. We came over the radio that we had a 23-year-old female coming in from the local factory. And even EMS, you could hear in their voices, were pretty panicked calling this in. And they said, we have a complete amputation of the left arm. It was below the elbow. We have a complete amputation of the left arm. We're bringing the patient in. Tourniquet is in place, and we're bringing the arm. Now, I'll tell you what resources I knew I didn't have, and that was the ability to put an arm back on, right? So this is a very, obviously these kind of surgeons, we'll talk a little bit about it, but they're very complex. So I know right off the bat, I don't have someone who can put an arm back on, right? Obviously, that's not going to be my job. So either way, this person's going to have to fly out.
And then the arm, you'll have to ship out USPS.
FedEx. We always FedEx those. Yeah. No, so again, immediately I'm thinking what am I going to do? What am I, as an emergency physician? I can do a lot of things, but what am I going to do with this amputated arm? I mean, I'm not sure. So I immediately talked to not our transport team, but our transport coordinators. And I'm like, hey, get a helicopter ready. No matter what happens, she's got to go, right? If we want any chance of this being a successful outcome, she's going to have to go somewhere else for that continued care. I'm going to have to stabilize her. Now, what's cool about this too, is that I'm glad I did, but I immediately thought to myself, okay, I don't know what resources I have, but let's figure out what I have. Do I have anyone? So I immediately talked to our, not secretary, but our coordinator that helps kind of, figure out what's going on in the hospital for me as the ER doctor. And I said, who do we have? Who is here? Anybody. Who is here that might be able to help me with this? Do we have a regular surgeon, a vascular surgeon? Do we have a trauma surgeon? Do we you know what I mean? I'm going to need some support here. And I was so lucky that she's like, well, actually, we have and I think he was a vascular surgeon, but he had also served like two tours in like Afghanistan.
Oh, wow.
I was like, yes, I want that guy.
guy.
That's the guy I want. If anybody knows how to take care of this, bring him. So,
Sure.
so we call him, and like I said, such a blessing that he was available and came in to assist me with this. But so this girl comes in, they've got her on the stretcher, and she's really not. I mean, they've given her some fentanyl, but she's really not freaking out the way you would think someone would be, just freaking out and in terrible pain, all this kind of stuff. She's got a tourniquet on that left arm. Like I said, the arm's completely gone. There's some like bone and tissue hanging out. And then in a cooler thing, they have the arm. Yeah. So, right. Yeah. It's like really, this is super intimidating. So
at least they had a cooler. I'll tell you right now, like we don't have a cooler in our ambulance for that sort of thing. So I'd be like, and we don't have like an ice machine. I'd have to be like, someone give me some ice. Like, I don't even know.
Right. And we'll talk about how to preserve that limb too. Yeah. A bio bag, something like that.
That's weird, man.
And that's the thing. And that's why I want to talk about it today, because I think I spend some time thinking about, well, what would this happen if this crazy thing happened? What would I do? And that really helps. It really helps in my career. So if you've never seen an amputation before and you're listening to our podcast, let this be the time that you stop and think to yourself, what do I have in my ambulance? What do I have in my facility? What would I do in this situation? And hopefully we'll be able to give you some tips on, like, it's really more simple than you think. Mm-hmm. Again, the situation itself, though, is super intimidating. So she pulls in. So obviously the first thing we do is we get a set of vitals. Her vitals are stable. I look at the arm, because how do you not? There was no reason for me to look at the arm at that point, but I was just like, can I see it? I don't know why. But so I looked at the arm, and then
it's off.
It's off. Yeah, that's gone.
That's
an arm for sure. And again, what a surreal thing to just like literally look at, like, someone's arm laying.
I talked to our sister about this recently, and she's like, she watches.
You talked to Kendra about
our sister? No, not about amputations. Just about traumas like this in general.
Gotcha,
she was asking about, I don't know, she's watching Chicago Fire or something, and she was basically saying like, oh, like that's like, it looks fake though, right? Like that doesn't look anything like that. And like my response is, no, like it does. Like it looks fake. Yeah. It looks faker on scene than it does in the movies to me. Like, and you have like this like block you got to push through when you see trauma like that, because it's just, you're just sort of like, that looks like a horror movie thing, and you're like, well, either horror movies are nailing it or real life. Right. You know what I mean? So it is kind of freaky, and it does look very much like you'd sort of think it would look. It's not this big different thing, but it almost, to me, like my mind just like tells me it's fake every time.
There's kind of like that separation between. Even in trauma situations that I see as an emergency physician, I think I'm just in a clinical context, so I don't really have a problem with them. You know what I mean? Even with like death and things like that, there's a little, not a block, but you compartmentalize a little bit. Okay, you expect to see that in that situation. Mm-hmm. But then, like, if I watch a movie that does, sometimes I'll get queasy. Like, I don't get queasy in person in a real trauma, but I'll watch a movie because you're detached, you're pulled away from it. You're not in the moment taking care of that person and patient. So this arm is, they've got this arm in a bag. It looks fake, but also it's just, kind of surreal. The mechanism, so what happened to this girl is that she was working with and I'm not familiar with the machinery exactly, but what it sounds like is it was a piece of machinery where you kind of like fed paper and products into it. So she had a leather glove on, and she was feeding it into this like compression mechanism thing, and it caught the glove.
And pulled her whole arm.
And it pulled her whole arm in. So it kind of like tore the arm from the... So it wasn't like some nice clean cut. It was like, again, she had like pieces of bone sticking out, pieces of muscle. Again, and I'm like, what do I do? So she's got the tourniquet on. The first thing I do is I say, okay, well, let's take down the tourniquet to see where we're at. The field at this point, when I say field, I mean like the amputated arm, the part that's still attached to her. There's no active bleeding. She's got a tourniquet in place. So I'm like, I'm going to take the tourniquet down.
Before you go on, let me just preface this by saying, as emergency providers, as pre-hospital providers, we will never do this. You will never take it. Absolutely. As soon as a tourniquet goes on, we're never going to take it off. So don't listen to Chris's story here. Don't take it to like, oh, this is what I'll do. Okay. Because we will never take a tourniquet off, whether we think bleeding's done and we're good to go or not. We do not have the ability to do that unless we're given direct orders by a doc to do it.
No, very good point. And we'll talk about tourniquet use here too, because as a part of this, the management of these types of things. But yeah, so I mean, and again, when I say I took the tourniquet down, it wasn't that I just willy-nilly like unscrew the thing
Well,
and let
yeah.
it go. I mean, I waited, like the vascular surgeon had now gotten here.
Yeah, you're allowed to do this sort of stuff.
We had got a bunch of stuff ready. I mean, even I'm not going to just take it down without being ready to intervene on what I find.
Right.
And I think that was kind of so I don't, the tourniquet's in place, it's doing its job, but now I need to see, especially since I'm going to transport this person in a helicopter, I don't want the second EMS team on the helicopter running into issues that I can deal with here in a controlled environment. So we've got all of our surgical equipment, we've got all of everything. We take the tourniquet down, and the amazing thing is that we take the tourniquet down and nothing happens. It doesn't start squirting blood everywhere. It really barely, it starts oozing a little bit, like the capillaries and like the skin tissue starts to ooze a little bit of blood, but everything's fine, which is also crazy to me. And we can talk a little bit about that as well, but it's like the body does a really good job. I mean, you got to imagine she's got her radial, all her arteries like completely severed through. They have essentially retracted and collapsed down, and they're not bleeding.
Right.
So one cool thing, and this is one of the reasons I'm glad I had the vascular surgeon there, because I think I would be comfortable doing this next time. But he said, he's like, obviously this guy's seen amputations. Most of our research about amputations, how to manage amputations, comes from the military, comes from Afghanistan, Iraq, all these kind of places. I mean, that's where we test out a lot of our theories of what,
trauma medicine,
quick clot and these things, and all this kind of stuff comes from there. So he's obviously seen this much more than I have, and he was saying, hey, you know what? If we're going to transport her, let's go find that radial artery and we'll tie it off so it doesn't start bleeding later on.
Just the idea of doing that sounds A, awesome, B, terrifying.
Right, no, and that's the thing. It's like, and now like having experienced that with him there, I'm like, okay, like I would think to do this next time, or I might be able to do it. So we didn't even really have to numb up her arm because because
it was off.
Well, that part, no, we didn't have to numb that part off. No, but I mean, like, we didn't have to numb up the part that was still like part of her arm that was still there because all the nerves have been severed as well. So like, it's not that kind of pain, right? It's so super weird. So we go, we get some forceps and stuff and go in there, and he finds the radial artery, and the way you find it is that it's the one strand of thing that's pulsing.
Right.
We're done for the day. No, so we find this pulsing vessel, and he ties it off with some suture so that EMS doesn't run into issues later on.
Right.
Because we don't want that to like all of a sudden open up and start bleeding during transport. That would be pretty extreme. So that's pretty much all we do, right? So we do this. She's hemodynamically stable. We get the helicopter team in. Obviously, we started on some antibiotics and stuff like this. The limb itself has been, and we'll talk about how to take care of these limbs, but EMS did a good job with that, so we just kind of leave that. We did x-ray both her part of the arm still on her and the part of her arm that wasn't on her. Like, we x-rayed that too.
That technician had to just take the arm and set it in the thing
to take an x-ray.
Oh my gosh, that's so weird.
So we x-rayed both of those. Obviously, I call another facility to let them know, and we transported her. Obviously, this is very rapid transfer. This whole thing happened within like 30 minutes. She came in, we did all this stuff.
Yeah.
IVs, all the good, and then got her.
She's flying away.
Yeah, flying away because you don't have that much time to put that arm back on.
Sure.
And she's a young 20-some-year-old female. Like this is her dominant hand too. This is like her right hand. Yeah, so even more so. Like, we're gonna do everything we can to reattach this arm. So that's the story. Exactly. But and obviously, like, well, I might have a picture of this I can show you later.
Okay.
You're not allowed to take pictures of this stuff. So
and you're going to find that at www.
No one else can find this picture.
Ill gross. Check it out.
I'm like, check out my OnlyFans page where you can see limbs. Just kidding. So, but anyway, again, so I wanted to talk about this today because it's not something we see very often. It's also this huge traumatic injury that can be very intimidating, very surreal. Seems like, what am I going to do? And I felt this, right? What am I going to do in this situation? And then really when it boils down to it, the management from an emergency standpoint is really straightforward. It's really straightforward and simple. So again, if you've never seen an amputation before, if you've never dealt with this is your chance to stop and think, okay, what would I do? Right? And so hopefully if you ever do experience this, if you're listening, or you're in EMS, or you're a nurse, or you're a doctor who's listening to this is your chance again to kind of say, okay, what would I do in that situation? So hopefully it's not as terrifying for you if it happens. Yeah. So the first thing I want to touch base on, and maybe you can speak to this, is just the different types of amputation. I was telling you about her mechanism where her arm kind of like almost got pulled. So There's a couple different ways things can amputate, right? So
Yeah.
you want to hit on that a little bit?
Yeah, I mean, it's interesting that you said you're in the mountains. Like, when you started the story, you're like, you're in the mountains. I'm thinking like, oh, is this like a ski accident or like some like a bear attacked her? And then of course it's like what it almost always is. It's some sort of industrial, you know, it's like human-made device causes the amputation. I know our father worked in a community that had like a butcher's shop, and I guess he ran on like clean amputations all the time where they like accidentally like took the hand with it and stuff. So there are lots of different types of amputations. There's lots, but there's lots of different presentations, you could say. But typically we divide them up into, you can have like a partial amputation where it's not cut clean through. You can have a clean cut full amputation where it's sliced right down. You can have things like partial crushes and crush injuries, and that's where we start to run into some complications. Like it's a lot harder for you to find that vessel and tie off. It's a lot harder for you to attach a limb where we've experienced crushing force, and now we have amputation of tissue alongside of that.
And so there's like the clean through and through. Those are, so we say clean, it means like a clean cut, essentially. Those actually end up being cleaner, like literally like in the sense that, it's a quick blade through the tissue. There's not as much surface area or opportunity for bacteria and things to get in there. Then again, like you said, the crush injury one, so the limb gets crushed, and then also like through that crushing mechanism, it's essentially amputated. That's way harder. So now you're not talking about just reconnecting vessels and muscles and tissue together to put that back on. You're talking about all the damage that it's occurred to that crushed piece, all the micro, damages to the vessels and the nerves and the tissues. That's going to be much harder.
Infection risk, depending on how long were they like trapped under this thing, or what was the crushing force like. And then you've got the toxicity of the body itself with compartment syndrome and things like that, which I think we should do another episode sometime soon about just kind of talking about compartment syndrome and crush injuries and stuff like that. But yeah, lots of complications with those.
And then the same thing, kind of her mechanism is this like tearing. So she had kind of like a crush and tear. It was literally like torn from the limb.
That's rough.
Even more so, very difficult to reattach these limbs. You're talking about like infection rate, and there's a lot more has to be done in order to, like, you can't just leave that either, right? Like even if you're going to not replace that arm, you've got pieces of bone, and that's got to be like
that's why you're X-raying,
down.
right? You're X-raying the limb and you're X-raying the torso, what's left.
Yeah.
Just so you can deal with all these secondary issues that you're gonna have to deal with in the future.
Right, exactly. So different types of mechanisms here that can occur. But management, again, like taking it back to basics, management of amputations is very straightforward and very simple from an emergency standpoint. Like, I'm not the one who's tying all these vessels back together trying to get this functioning arm to work. I'm the one stabilizing the patient. Stabilization is, again, pretty straightforward. And it's going to start with bleeding control.
Right. So when we do treatments, a lot of times what we're doing is we're helping the body help itself. So to really understand bleeding control, I think we need to talk about hemodynamics first, and like what happens in the body, right? So if I were to cut off your arm, what happens in the vessel? There's a couple things, right? First and foremost, the vessels know to start to spasm, right? They clamp down, they spasm themselves so that the hole will get smaller and it will stem the loss of blood.
And that's essentially that's what happened to that radial artery, right? This big vessel off. It did it itself. It had spasmed down and and retracted a little bit, so it stopped itself from bleeding.
And this is how many minutes later after transport and stuff. So these mechanisms last a long time, and a lot of when we put a tourniquet on, we're assisting that clamp down method that our body's already doing, right? We're helping that out. So we're never going to beat the body at healing itself, right? We're never going to get better at it than the body already is set up to do. But we can help those mechanisms and improve outcomes with that. So there's the clamp down, and then there's also clot formation, right? And this is a process. Hemodynamics take some time to understand, but this is a process. But basically, what starts to happen is you have, breakdown of fibrinogen. You get the creation of fibrin. You start to get that mesh network that covers a vessel, and then the platelets. We know do what platelets do best. They start to get sticky, and they kind of get caught on that net, and they create a clot, a good clot, not a bad one like we usually talk about, but a good clot that's going to block off the vessel and stop the blood flow. It's basically like a micro scab, right? It's happening on a microscopic level, but it's scabbing over to prevent blood flow out. So if we have to compare those two mechanisms and our treatments for each, or treatments that help each, tourniqueting is like that clamp down, and putting direct pressure is like helping that clot, right?
Yeah.
There's two things we do. Initially, our first response to anything is going to be start putting pressure on it because it's just what we can get to the fastest, right? So even if it's an amputation, I know you're thinking we got to tourniquet it, absolutely. But you don't have a tourniquet in your hand when you walk up to the scene. You have your gloved hands though, and you can start putting direct pressure. So direct pressure, first and foremost, we're going to start putting pressure on that wound, wherever the bleeding is.
And people underestimate how effective direct pressure is, even in like a surgical situation. So let's say I had taken that tourniquet down and her radial arteries started just squirting blood at me. Literally all it takes is for me to just to grab that thing, right? Just like pinch that vessel or like put direct pressure, like with my one finger. We always teach that too. I mean, when we teach bleeding control, we teach like using two hands to really block that thing. If you can do it with one finger though, that's actually more effective because if you can really pinpoint where that bleeding is with one finger and stop it, holding pressure with just one finger is enough to save someone's life, right? Because they're not going to bleed out, especially these vessels that, you know, these muscular vessels that are really pumping like arteries and stuff. You'd be amazed at just that is a life-saving intervention.
Right. When we teach stop the bleed classes and trauma classes, the first thing that we teach is kind of evaluate the wound, take a look at the wound, try to find the source of the most bleeding because there might be multiple vessels that are cut and they're all bleeding different ways, but try to stem the flow where it's worst first, right? Mm-hmm. And we start by direct pressure. We want to try to, if we can, get some gauze or some sort of clean thing to put direct pressure. And we can even start to pack wounds if we're in like a more transitional area where it's not a limb and we're dealing with like a shoulder or a groin wound where we obviously can't tourniquet that, right? What are you going to tourniquet the waist? You're going to tourniquet the neck for a head wound? Right. No, all that you can do there is pack that wound. So we start to kind of push gauze down into that. And so that seems like very shoving things in there seems like a bad idea, right? But remember, these are relatively clean things, and we are also dealing with a life-threatening situation. This is quite literally life over limb. So hemodynamics, we got to understand, it's clamping down, and it's creating a clot. When we put pressure, we're helping with both of that. We're helping it clamp by putting direct pressure on it. And we do this like CPR position, lock your elbows, you know, we want to put pressure on this thing. It's not going away once we put it. As much as like I've done this, you know, on scenes where you're like, is it working? And you like take your hands off and look.
Right.
Well, any clots that you just helped form just busted from the blood flow and you just ruined the whole thing, right? So we can't do that.
And that goes back to what you said about the tourniquet thing too. So the second thing we're going to do is we're going to place a tourniquet, right? And we can talk about like how to place that tourniquet appropriately. But once you place that tourniquet and you crank that thing down and you get the bleeding to stop, you leave it, right? You don't check later on because the whole process of clotting and everything starts right back over as soon as we let that thing start bleeding again.
Right.
So that's why it's really important to write down the time that you put the tourniquet. That's why these tourniquets have a space for you with a marker to write down what time did you put it on there, because you'd actually be surprised how long you can leave a tourniquet on for. But we need to know, we don't want it to be too long. So we do need to know so that when the patient, comes to me as the emergency physician or the surgeon, we can say, okay, this tourniquet has been on for 15 minutes, 20 minutes, 30 minutes. There are some time frames that we want to release some of that pressure so we don't cause more damage.
But that's a you thing. It's not a me thing. And that's the problem with, I think, tourniquet education is it got a little bit of a bad rap. We didn't really realize how useful these things were until we had some wars in the Middle East and we started dealing with a lot of, because tourniquets got left on for longer than we thought was appropriate, and things turned out just fine. And I think the stat, and I'm sure I'll get corrected by this again, internet, I challenge you to correct me, but I believe it is there has never been a issue with losing, like getting necrosis and losing a limb from like a bullet wound that we tourniquet. Mm-hmm. Even when that tourniquet's been left on for, I think it's up to 2 hours. So like we're taught this initially, and we might get taught in like an old school way where it's like, no, like tourniquets are bad, especially in nursing. That it takes a little time for nursing to catch up. But nursing education is still like, no, tourniquets are bad. You don't want to put a tourniquet on because what if they lose the limb? Well, first of all, what's the alternative? What if they lose their life because they're bleeding out? I'm putting a tourniquet on. You know?
Yeah. And all that tourniquet research does come out of the military. So much so, and it's used so much in that regard that now a lot of our military, I know special forces especially, literally the fatigues and what they have tourniquets built into them.
Yep, you just twist
both arms and both legs. With the idea is that if you're my you're my buddy and you go down, I can crawl up to you and just the tourniquet's already on you. I just twist it to stop bleeding. Yep. They really are extremely effective, and we should be using them for these types of things.
So just quick review on tourniquet application. Please, yeah. We want to do about 2 inches on the body side of the injury, right? So about 2 inches away from the injury.
Proximal to the injury.
Proximal to the injury, and we want to cut that blood flow off. We need to twist this thing until the blood stops. We don't twist until it hurts. We don't twist until it slows down a little bit. We're twisting this tourniquet until it stops. The blood is done. If we've twisted it as tight as we possibly can go and the bleeding still hasn't stopped, this would be a very rare case. Mm-hmm. We can apply another tourniquet proximal to that one, 2 inches away, and cut it off more. And we're just kind of working on systematically clamping off and pressuring down on that vessel and collapsing it. We're taking the bone, and we're taking the tourniquet, and we're smushing the vessel between the bone and the tourniquet, which is why it's got to be done on limbs. The other thing is, if you've ever put one of these things on the patient, it is not a fun experience for the patient at all. I'm not surprised at all that these guys gave fentanyl to this lady.
Right. I'm
very surprised that she wasn't in more pain, not from the amputation, but from the tourniquet itself. Tourniquets are incredibly painful when they get put on. Your patient will start to scream. Guaranteed, when you initially put this on, your patient will start to scream. And I think it's a hard thing as providers, because we're used to making things better, and pain makes us think things are going worse. It's hard for us to continue to crank down on that thing. You know what I mean? No one gets any pleasure in doing that. And if you do, you shouldn't be in this field. Right? So if you're cranking it down, they start to scream. You want to stop or go easy, and you just can't afford to do that because we're in a life or limb situation. And we have to be able to save that life. We have a major bleed here from this amputation. We have to stop the bleeding. Mm-hmm. So just keep that in mind. Like, it's not going to be a fun experience for them. It doesn't mean you're doing something wrong. It's doing its job. It's difficult, but we got to crank it down, and it's going to be very painful, which is why if you're a medic or an advanced EMT that can give pain medication, we certainly want to be giving pain medication as soon as we can to try to treat that pain.
No, definitely. And like I said, then the other caveat there is, like I said, once that thing is in place, we're going to leave it in place from an EMS standpoint. And again, we're going to document the time that we put that on. And when you said, going back to what you had said about the 2-hour thing, that makes sense, because when we do, when I was in medical school and we would, in a residency, and I would scrub for surgeries, if we were doing like a repair on an arm or a leg, a lot of times they would tourniquet these things in surgery so that they had a clear field, because it's hard to operate on something that's bleeding all over on you. So they would tourniquet these things down, and they would leave that for 30, 40, 50, 60 minutes before they would be like, okay, we'll release the pressure a little bit. So yeah, I mean, you'd be surprised how long you can go. And the other thing that this makes sense is this girl that I had, this patient, she did have that limb reattached. Well, that limb was not attached for a good 2 or 3 hours. So the limb can be completely unattached for 2 or 3 hours and then go back on. And it depends on what limb. I want to say, like, for her arm, it was like an hour and a half is how much time we had, or something like within, and that was for reimplantation. That was for putting the arm back on.
Yeah.
Well, if that can happen within an hour and a half, then a tourniquet, you know what I mean? Like cutting off that blood, because there's still some micro blood flow occurring, probably in that case. So again, going back to the basics of bleeding control, we're going to do direct pressure. And then especially for these amputations, we're going to go to tourniquet, and we're not going to delay that tourniquet. Like you said, it is very much, the research shows that tourniquet use is important. It needs to be done. We should be going for it immediately.
Yeah, old school was you start with some pressure, and then you elevate, and then you push on pressure points, and then you think about, okay, I guess I can risk a tourniquet. Now it's like you see an amputation, throw a tourniquet on right away. You don't have to. If you've got it ready to go, you don't have to jump with the
textbook. Still might recommend like pressure and elevation and then tourniquet use, but the whole pressure point thing, I haven't really seen that taught in a long time.
And the pressure and elevation are like things that go together. Like when we're putting pressure, if it's a limb, we can be elevating it at the same time. It's not like we try this and then that doesn't work, we move on to this next thing. It's not this systematic thing. We're going to jump right in and get it going.
Exactly. So the next thing, so once we've got that bleeding controlled, so we've done direct pressure, and we've done tourniquet use, the next thing we're going to do is make sure that we're hemodynamically supporting this patient. So how much blood did they lose, that sort of thing. So we're going to be looking at things like their vital signs. Are they super tachycardic? Is their blood pressure low? If it is, obviously we're going to give fluids, right? We're going to get IV access, 2 large bore IVs if we can, and we're going to start giving fluid resuscitation. A lot of the research out of the military for these amputations things have also shown that we probably should be considering whole blood transfusion or giving whole blood earlier than we would normally in someone else who's hemodynamically unstable. So when I say hemodynamically unstable, I mean their blood pressure's low.
And we're not going to wait for them to start getting worse and now give them the blood. In this type of situation, we'll give them the blood pretty early, even though they're kind of maybe they're tacking away or their blood pressure's fine. We're going to start.
We're going to start
early.
considering it early. So if you start to give fluids and their blood pressure's not responding, giving them blood earlier on is not a bad idea. Now, a lot of the people listening, maybe you guys don't have access to blood. Do you guys have access?
We don't have blood.
Yeah, so a lot of EMS agencies do not, but it's just something to keep in mind. Like I said, if you've got longer transport times and you guys do carry whole blood, when it comes to amputations, if you're having any trouble with hemodynamics with just fluid resuscitation, think about whole blood transfusion earlier on.
It would be very common for the helicopter crew would probably have a trauma nurse and a helo medic, and they would be trained in under the nurse's licensure to be able to give that blood product. So they're probably, and there's an example of an EMS crew, if you will, because the nurse is acting as EMS as well,
right?
Who can give whole blood product and get going. So
exactly.
they'll do that for sure.
Exactly. So we've got this amputated limb, and all we've done is stop the bleed, right? Direct pressure, tourniquet use. We're going to give them fluids and blood. That's it.
It's boring, man. It's boring.
Right.
It's like very exciting to watch. It's really boring to do.
Yeah,
like,
exactly.
I'm just done.
And that they said, so again, like this situation that can be extremely intimidating and terrifying when you really bring it back to basics, it's pretty straightforward management, right? Pain control, obviously we need to consider. For people who do super long transport times, IV antibiotics is probably something we're going to give a dose of and things like that too.
How do we transport the limb? We do want to touch on that.
Yeah,
quick.
so that was so we figured out how to stabilize that patient. Pretty straightforward. We do have this limb though.
Pieces of a limb or whatever.
What do we do with that? Right.
So what we're trained is you bag it. You then put that bag in a bag, and the second bag should be full of ice. So you never put ice directly on the limb at all, and you want that basically there to be a barrier of a bag. Preventing direct ice exposure to the limb itself. So that's why you're going to double bag it and put ice in the bigger bag.
Right. Or put it in milk.
No, that's for a tooth.
Okay, no. Oh, good point. Yeah, don't put it.
Okay. So, hey, I soaked this in 2%. Is this arm going to be okay?
It's
like, what have you done? No, but that's a good point, though. Like, we don't want to get limbs wet, and we want to try to keep limbs as dry as possible. That's why we don't want the direct ice contact. We don't want it to freeze the tissue in any way or cause necrosis.
And those are the two big things. So you want to keep it dry. So obviously sterile. Goes without saying. We want to be as sterile as we can. Now, this limb might be not sterile looking, but we're going to try to be
sterile. We deal with clean. So that's what we're going to try to do.
We want to be as sterile as we can, as clean as we can. So we're going to be obviously handling this with gloves. We're going to be using as much as we can, like, sterilized bags and things like that. The two things we want to avoid, and that you touched on, is one, direct contact with ice. Because if we have a direct contact with ice, then the tissue freezes, and then that tissue is pretty much damaged and can't be repaired. So we don't want to directly freeze that at all. We also don't want the limb to get wet, because like you said, if it's soaking wet and we put it on ice or we put it in water or something like that and it gets wet, well then that tissue becomes all emaciated, and again it's not something we can do anything with at that point. Yeah. So we want to keep it clean and dry. And just like you said, we're going to put it in a bag that's going to keep it dry and clean. Then we're going to put that bag usually in another bag just for safety reasons, but then the ice inside that bag. Or like I said, these people had a cooler, so they put the limb in a bag
and a cooler full of ice.
Well, and then they wrapped it with like a towel and then put it in there.
So we want it cold because we want to slow down that metabolic
situation. Slow down the damage.
We still want it cold. We just don't want it wet or frozen.
Exactly. The other thing too is we don't want to wrap that with like gauze or anything like that. You want to just put it in a bag. Don't wrap it with anything, because anything you wrap it with is going to get stuck to that tissue. You know what I mean?
Yeah, kind of mixed in with it.
Yeah, so we don't want that either. So just leave it how it is, put it in a bag, and then like I said, we put it on ice. And like I said, that's it. I mean, it's really, like I said, I tell the story and you're like, oh my gosh, like it's intimidating. What do I do? That's all you do, right? I mean, you protect the limb that way. You stabilize the patient with good bleeding control and supporting hemodynamics, and then you get them somewhere where they can potentially get this place put back on. Now, this was an interesting conversation I had with this surgeon right after she flew out. I said to him, what are the chances that this limb is actually gonna like do well? And he's like, it's not good at all. He goes, the problem is she's a young 20-something female who this is her dominant hand. He's like, if we don't try, there will always be the question of why didn't we try? So we'll finish this conversation off talking a little about that reimplantation thing, because from what I've experienced and what I've seen, if I ever lose my arm, just throw it away. Like, I would rather have a nub. No, but seriously, because, and I actually like have made a point of telling Lindsay this as well. Like, hey, just so you know, I don't want my limbs back.
Don't go
like
find it.
Some
Let
weird
the bear have it.
advanced directive I have. Yeah, exactly. So, but the reason is that now it becomes the job of multiple surgeons, usually a vascular surgeon, an orthopedic surgeon, to come in and reattach not only the tissue, but the muscle and the nerves and the blood vessels, all this microscopic, and they can, and it's amazing. But especially in like a tearing injury like hers or a crush injury, the chances of you getting any good function back in that limb is really low.
Yeah.
The other thing is that it takes more than one surgery. I mean, it probably...
Putting your body through a lot.
Yeah, you got to go through multiple surgeries to get to the point where you finally get a not well functioning limb. You know what I mean? And the thing is too, is that you can have a lot of residual pain. I mean, you hear about these patients who have phantom pain in a limb that they no longer have. That happens as well. So I've actually heard stories of people who have had limbs reattached and have had such problems with them that they've gone back and have them taken back off.
Wow.
They've literally said like, hey, like just amputate this thing.
It's like a cosmetic thing. It's like, hey, I want my arm back because it's my arm.
Yeah. So, you know, and nothing that this isn't going to change anything we do in an emergency situation or in EMS, but sometimes it is a little reassuring to know that the outcome of that limb going back on is probably not great anyway. So focusing on the patient and making sure that patient is as stable as they can be and that you're saving their life is more important, obviously. But, you know what I mean, more important than worrying too much about how are they going to get let somebody else figure out how the limb's going to get back on, if it's going to get back on, right? Our job is to stabilize that patient. And now I feel bad because I feel like we took this like really cool trauma situation and just made it as boring as it can be because the management is so simple, right?
Well, I don't think it's boring. I think it's exciting. This is something that, you know, very basic providers can handle, right? And I do think we have to train ourselves on scene to realize like there's going to be a point where you've done all that you can do. Like, hey, the fluid's going, it's tourniqueted. It seems like I should have a lot to do right now, but I'm just going to kick back and we're on our way, right?
Yeah, exactly.
So, and it sounds like from what you're saying, you heard it here first, folks, it just doesn't matter because it's not going to work out.
No, I don't mean it that way. I don't mean it that way. Like I said, there's plenty of successful surgeries where limbs get reattached. But again, it's not super simple. It's not like, oh, yep, we stitched it back on and you're good to go.
Yeah.
You know, it's a lot of physical therapy, multiple surgeries, revisions, things like this. So that patient does have a long stretch of treatment to go through before they can ever get to a point where...
But it's the life-saving intervention that's
exactly.
the easiest and has great outcomes and that we can get involved with. And that's what's so cool.
Exactly. So, cool. You want to sign us out here?
Sure. I mean, that's what was our sponsor again?
Rapid Rescue. I'll do
Rapid
it.
Rescue?
I'll do it.
Go for it.
Rapid Rescue. So our sponsor today was Rapid Rescue. Again, we want to thank them for sponsoring us today. Check them out at rapidrescue.com. Again, they're doing some EMT and paramedic refresher courses through JB Learning. If you need a refresher course, check them out. If you're enrolled in our prep program for the NREMT, we offer that as a complimentary part of our program as well if you need to take that refresher before you go take that exam again. So again, we hope that this was an interesting podcast for you. Hopefully we didn't take away all the glamour of amputations, but again, rest assured that what you do makes all the difference in the world when it comes to these extremely intimidating and overwhelming circumstances sometimes. So thank you guys for what you do out there. We appreciate you taking time for us, and we will see you next week.
Keep your life and your limbs safe. Stay sweet. Hey guys, hope you enjoyed the episode. If you're an EMT or medic student, or an advanced EMT student, or an instructor of those students, we have a program just for you. With Seitz and Siren's NREMT prep program, you get video lectures, over 15 hours of really vetted, great content to help you through your program and help you prepare for the test. Check it out at www.seitsandsirens.com.